take that a step further and say, now that we can sequence and have all this information in the gut, how can we better take that data and put it into some sort of a usable format for the end user?
So yeah, that's a great point. And it's information overload. In our report, we take a top-down approach. First, one of the first main domains that we look at is essentially, are you in dysbiosis or not? So we have a dysbiotic score, what we call the gut wellness score.
Can you also say what dysbiosis is for somebody that might be hearing this? Is just like
it's a contentious,
really high level.
Yeah, dysbiosis or a dysbiotic microbiota is a contentious term. I've generally shied away from it in the past. However, because a lot of people kind of vaguely understand it, I do use that term. I generally like to talk more about a disease-associated microbiota. So is your microbiota basically working against you versus working for you? Okay. So you can have certain functionalities that are perturbated, like we talked about bile acid metabolism, for instance, which is a main issue, particularly in the West. And a lot of that is driven by diet, not surprisingly. You can have issues with degradation of mucus. So if you actually look at in the colon, if you look at the tube, if you did a little cross section, the microbes in the luminal space inside that tube, they're not touching they shouldn't be touching the brush border. The brush border is the cells that line that tube, the epithelium.
Yes.
You have goblet cells secreting mucus. Okay, they're basically offering this barrier to push out the microbial contents, because a lot of microbes on their cell wall have endotoxins. Okay, these are lipopolysaccharide type molecules. Just think about the lifespan of a microbe. It's maybe living for a couple days. Okay, you'll have colonies, obviously, that are proliferating. You have microbes that have a high rate of turnover and lysing. You have these endotoxins now, potentially coming into contact with the brush border. If you have compromised gut permeability, endotoxins enter into circulation, spur inflammation, spur meta-inflammation, are tied to any type of chronic disease that you want to talk about that ails our society nowadays. We're talking about diabetes, obesity, even issues with neurological type diseases. So a dysbiotic microbiota is basically, again, in the simplest ways I can put it, is a disease-associated microbiota.
Yeah, that makes sense. Yeah, but keep going with saying what we would do with this information. I kind of threw you off.
Right. No, it's fine. So we have a top-down approach. So we essentially benchmark the configuration of your microbiota, including taxonomy and function, okay, against 8,000 different metagenomes. Okay, so the data that we've curated is spanning multiple continents, dozens of different countries, with people of varying health issues, whether we're talking about IBS, whether we're talking about cardiovascular disease. Again, insulin resistance is just so prevalent, unfortunately. And then also very healthy individuals. And a lot of times these are people from non-Western countries, not surprisingly. But we're actually able to derive a score of where you sit on that spectrum and the underlying features and functions that are driving that. And from that score, we then get down into some really important different domains that are either going to keep you in that state, because you can be, for instance, this is where I want to bring in resilience. You can have a dysbiotic microbiota that is showing signs of maybe IBS, features associated with IBS or something like that. But you can be very resilient, meaning it's hard to get that configuration into a healthy state where we want to bring you. So why is someone's microbiota resilient? Well, you can have a lot of redundancy in functional features, things that are trying to reinforce you. Like I can almost think of it like this: if you have a ship moored, it's almost these anchoring elements that are holding you in place. So with our resilience score, we're looking at those anchoring elements and seeing if someone is in a health state, why they're in a health state, what's driving that. Because if they are, we want to reinforce those. Conversely, if someone's in a dysbiotic state, say they have a lot of functionality primed for producing endotoxin, like I mentioned earlier, we want to address those. And in many cases, we have to try to do some bottleneck events where we decrease the populations of those microbes expressing those functions, and then try to, over time, repopulate the gut with commensal microbes or beneficial type microbes. So we can get more granular with the anchors. We can look at things, not just bacteria, because when people talk about the microbiome, they're hyper focused on bacteria. That makes sense. If we look at a normal fecal sample, anywhere from 90 to 95% of your microbiome is bacteria. So everyone goes to bacteria. There's other really important elements.